Can we start now? Can we start? Yeah, yeah, no problem.
Okay, I guess we will start. Good evening, everyone.
All right, good evening.
Respected Mr. Rahul sir, members of the Safe Dental Updates, and dear doctors. So we welcome you back for our 53rd episode of Learn from Our Master series
Hello.
by Safe Dental Updates. And it's a pleasure to be here. So for those who are attending our webinar for the first time today, I would like to do a little bit of introduction. So we are Safe Dental Updates, a dental platform in which we believe quality education ensure predictable outcomes for dentists of all disciplines and abilities. Our organization is established based on the observation that the dentistry is complex and requires ongoing learning experience. So we conduct various webinars and workshops to enhance the skills of dental professional and guide your dental journey. So without further ado, let us start our series in which our topic of discussion is precision meets efficiency, the streamlining lab communication for optimal patient outcome, given by Mr. Rahul sir. To speak a few words about sir, Mr. Rahul Ramek Kakodkar is a managing director and a technical consultant of Precision Dental Studio Limited. He's also a trainer for Ivoclar Vividend and consultant for Noble Biocare. He has completed all the modules on occlusion with Dr. Dawson's in the United States, and he has been an award winner for the best technical excellence in the industry. He has been on the advisory board of Dental Technology since the first issue and an editor for the Dental Technology magazine since April 2015. He has contributed for various articles across the globe and also have helped students in their thesis program at the university level. And he is a specialized for full arch reconstruction, smile designing, and implant superstructures. He does the planning for big case by learning and introducing those into the company on regular intervals. So without wasting more time, I would like to invite Mr. Rahul sir for today's discussion. Sir, please.
Thank you, Shanu. Thank you for the introduction. So, since Shanu has already introduced me, I'll just take one more opportunity to go ahead and just a moment. Go ahead and share my experience with the same. Well, I am basically a dental technologist or dental lab technician, as everybody knows. So, what exactly is a dental technician? So, a dental technician is not just a regular lab guy, as everybody claims to be, but we identify ourselves as a part of the dental team who, upon prescription from the clinician, make custom made solutions and appliances. Now, why I specifically mention this is that we as dental technicians, one has to identify him as a part of the team and not just somebody to do as per what the clinicians believe can be done, but you can take the suggestions, uh, take their point of view, and discuss for a treatment plan and so on and so forth. So about me, I'm basically a pharmacist to start with. And I did my dental technology from Government Dental College, Mumbai, way back in 1992. So it's almost 30 years now, uh, more than 30 years. We started a lab called Precision Dental Studio Limited way back around 28, 29 years back. Uh, I also happen to be working as a consultant for a few other companies like Ivoclar, Vividend, Noble Biocare. One of the most important highlight in my career was doing my uh, full arch reconstruction course with Dr. Dawson Institute in Florida. So that's where I got to learn a lot of things, because I believe occlusion is one thing which has been grossly neglected in our profession. And the fundamental of any restorative dentistry, or the fundamental of the whole dentistry itself as a subject, is occlusion and tooth morphology, which has been neglected unfortunately in our education system. uh, I also happen to be, winning a part of the world tour with Nobel Biocare when they came in, and won couple of awards in their creative circle. I also happened, my smile designing cases won award at the Miami Dental Competition. We specializes in full arch reconstruction and smile design and implant superstructure. That includes the planning stage. And as I mentioned earlier, I'm basically a key opinion leader to a few other companies like Ivoclar, Breeden, Noble Baker, Infant, and many others. I also recently I was also uh, made a fellow of ITI. ITI is International Team of Implantology. It's basically based in universities all across Europe, and I'm the only dental technician in Asia who is a fellow of ITI. So let's talk about today's topic. So today's topic, I'm supposed to cover something regarding lab communication and how we can get that optimal patient output, and we can get the best out of it. So as per my opinion, and generally everybody would not disagree with this, patients don't buy your treatment. What they buy is basically the experience before the treatment. So nowadays patients are very smart. They know what they want, they know what they seek, and this is what has been quoted on every podium by Christian Coachman, good friend of mine. Christian Coachman, he started DSD. So what we have covered here is basically impressions, material handling, preparations, uh, clearances, margin, finish line, bite, instructions, shade, material of choice, and the timeline. So pretty much we are trying to cover everything in this 1 hour. So let's squeeze in whatever best we could. So regarding communication, the single biggest problem in communication is the illusion that it has taken place. So many a times we believe that the communication is done, but there are certain areas where could have been better both ways. And, these kind of small things lead to a bigger catastrophe. So we try and be very careful about it, because we understand that communication is the key to the success in whatever we do in our everyday basis. That's why we have dentists working with us, or communicating with the clinicians. So what exactly, when I say communication, uh, we have something like a Monday morning motivation. So it's quite unusual to begin a working week, and it can be an inspiring aspect as well as it can be challenging. And I leave up to you to decide that. So this is how it came. Um, this is basically that I want to start a full mouth case and need excellent fit, retention, aesthetics, high point. So, the first thing is we ask for a reference model, whether you have made any provisionals, any pictures, or, anything for the referral. And the clinician says none. And this is exactly how it starts. And okay, when do you want the case? Tomorrow morning. So this is basically, most of the lab guys would go through. This is just a blooper kind of a thing, but this is a real incident. And poor guys go on, work whole night and try to deliver something. But that's a classic recipe for disaster. You can go wrong on many areas, on many fronts, and this kind of situation, or these kind of cases cannot be dealt purely by instinct that this is going to be like this. And it needs a lot of understanding, a lot of planning, a lot of communication to execute this kind of situation. So let's understand what all we need. So the essential elements of communications are basically a good impression, a good lab note with all the details, good pictures, and a decent timeline. So I have classified. This is a confidential classification, but this is generally how we look into everyday, work what we get. The I don't call it the good, bad, ugly, but good, bad, and the deadly. So we will just walk through this classification throughout our presentation. So what is good, what is bad, and what is deadly? So these pictures tells a lot about it. So a good impression can be something like this, which you can see. It's kind of a decent prep. You can see the margins are there, and it's something which is
So please try to share your screen, sir.
Can you guys hear me now?
Yes, sir. Yes, sir.
Okay, fine, good. So this is where we were. So you can see what is a good impression. A bad impression would be something like this, wherein it has a drag, and deadly impression is there on the right hand side corner. So you can see how and what kind of work we get, and this is something which is not very often do we get these kind of things. But yes, I mean, I would deny that we are also a part of this whole business, so we do get these kind of situations. So we will just understand what leads to these kind of models or this kind of impressions. It's basically hand skill. It has something to do with the handling of the material. So when they are handled good, the good handling material, with some basic sense, you can have a good output. The second image is something where you can see the wash is not even flown well over the putty, and the third impression is something which is put as an opposing model, and you can see how it's been sent to the lab. So uh, these could be easily avoided. So what is a good impression? A good impression is basically a primary input from the clinical side to the lab, and the most crucial step to obtain a desired output. So good impression turns out to be good because of right material, the handling quality, if it is retrieved well. The most important aspect is whether it is studied well or read well. This is something what most of the clinicians, most of the lab guys, even they're trying to miss it. Uh, Also, the a post coed, it should be disinfected before it is dispatched. That's basically a good morale clinic, or somebody who is ethically, holding themselves responsible would definitely do that. Uh, Without getting into detail of how an impression is taken, these are some steps what we try and share it with the clinic. You know, of basically a two-step impression, so that you can see the wash is completely and nicely flown all over the putty. Now, as I showed in my earlier image, you can see that the putty is at two different levels, and there is completely a hard body which is in between, smudged in between, or stacked in between. So what happens is there are two levels of, there are two different levels of impression material already there in the tray, and that leads to a model which is now also at a two different levels. So what happens? Uh, the crown would look okay, even if in the area where the prep is done, the margins would look okay, but where would be the problem? The problem would be at the area of occlusion. Since it has an imbalance, the model will also have some small disturbances that would lead to the final outcome, wherein you would say that it is completely high, and in many cases we have noticed, and also you as clinicians would have noticed, that you have taken off a lot of porcelain or a lot of zirconia, and on the model it's completely out of occlusion, but in the patient's mouth it is still very high. So nobody knows what it is, but it's just that kind of a small. That's why I said even the lab guys don't tend to read the impressions well. That with our experience now, we can say that we can read an impression and tell them that this is exactly where you would land up tomorrow, and it does happen. So these are good, nice preps well retracted, nice polished. This kind of a preparation would always give you the best optimum results. You can also see how the papilla is being managed here. So into an aesthetic zone or a high aesthetic cases which we tend to do every now and then on a everyday basis. These are something what we get like pretty on a pretty normal day. So what a bad impression. A bad impression turns out to be bad because of incorrect choice of material for specific cases. Like it's a multiple unit full archery construction, and you cannot just take an alginate impression and make a model and ask the lab to do it. No. The reasons is as a lab we would need to have multiple models for verification. One would be a die model. One would be a solid model. We will have another model to counter check the final before it leaves, just to verify whether it is following the gingival contour, the emergence profile. And there are a lot of aspects where we tend to verify each and every case. So the material choice becomes very important. Poorly handled impression material. A lot of people don't tend to train this part to their chairside assistant, because many a time the chairside assistant are somebody who tends to mix it. So there is something called as a ratio which has been prescribed by the manufacturer, which is not been followed. Poorly recorded impression is poorly placed, premature with the withdrawal. So we are sometimes we are in a rush, patients waiting, or patients tend to be uncomfortable. We tend to withdraw it before it is actually reached the setting time. Most important aspect here, when I showed the earlier picture where there was a drag, is because of isolation, not enough isolation, not good retraction. So I would not say that you may have to use retraction, but there are other options for a retraction. Or you can use some gel, or you can use newer products. I think 3M has, and a couple of other companies have, where you can retract the tissue for smaller units. It works really well. Also for digital impressions or digital scans. Uh, Again, as I mentioned earlier, study your impression before it is sent to the lab, poorly packed and not disinfected, and sometimes all of the above. So it never ends. So most of the time we are asked to. So what is the solution? So solution is, most of the time we are asked to just scrape and proceed, and this purely lies with the judgment and the experience we have. And it's not that I mean, of course we have a experience to it, but it's not that every time it works in our favor. We can go wrong. We treat ourselves as humans, and to err is human. We can definitely go wrong. Most of the time it works, but many a times it doesn't work as well. So sometimes we get the feedback that the margin has gone. Please add, and that's something which is not an ideal situation, because margin has been planned. If it's in PFM, you just can't extend, adding ceramic and leaving a whole bunch of unsuspended porcelain there. And with full contour zirconia, which is now something which is regularly being used by every day as a solution, you just can't extend it. So as a solution provider, what we do when we are in doubt, we print resin crowns, uh, and we can send it for a trial to verify the margin fit and the eye points, if in case we have a doubt with the model or the impression. Just to salvage that situation, the ideal would be to get another impression, but I'll explain this why we don't get it very often. So, that's the last point. The impression would be the best solution, but having said that, nobody likes to hear it from the lab that they need another impression. So, going further ahead, what are the good preps? So you can see the good preps, they are all lined up, nice margins, good retracted, parallel walls. Now this is the combination of crowns as well as laminates. There are lower laminates, the canine is the laminate. The rest of the guys in the posterior and the other side would be crowns. A bad prep. Now this is the diastema closure case. Now you can see, um, and it's prepped for laminates, all right? So you can see there is a whole lot of space in between. How do you squeeze that kind of a diastema? By just doing a laminate, and the papilla is also not been created. So what happens to that, black triangle? How do you compensate this and get into a symmetry where you have done only 4 laminates? So this is something which is really a challenge. The deadly or the worst prep would be something like this, where the requirement would be that everything should be aligned. Patients want a smile in arch form, and we need the best outcome because patient has been promised. So look at the impression, look at the model, look at the preps, look at the angles, look at the deviation, and this is something what we really don't accept from the clinician, and this has to go back. This has to go back from the to the drawing board actually. So regarding preparation, this is a small guide. Ivoclar Vivaden printed this years back. I'm not sure whether they still, gave it away or they have it, but this is what we take pictures of. So we have a small PDF of the same, and we send it to the clinician. This tells you step by step procedure of how a good prep is made. So we then don't tend to educate them, for every crown and prep design. But what we do is we give them something which is standardized. We give them something which has been time tested and which is been made by some company who has a reputation for which we use their product. So, if you just copy this, and mind you, dentistry is not about creativity, but dentistry for me is copying nature. And when I say copying nature is, you should understand what is in nature. You should understand how the tooth looks like. One should understand how tooth needs to be prepped. What would be the final outcome if the tooth is not prepped in a certain way? So, it's very easy to just copy this step by step, and you are home. So I always tend to mention this in my lectures and whenever I speak, that there has to be a roadmap, and the roadmap is a guide. So if you are struggling with your prep, you just go and find a good prep design book or something which is something like this. Very handy. It's a very small thing. Just keep it, just copy it step by step, and you are there. So it's not a big challenge. Having said that, it's just a procedure what you just have to upscale yourself. What we hear most of the time nowadays is, when we say ask for prep modification, is patient ko RC nahi chahiye. So that's the most common thing, that I can't prep more because the patient is not ready for an RC. This is something what is pretty new now, because in my earlier days, the earlier days practitioners, they used to decide and dictate how the treatment would be. But nowadays, the patient more or less is the driving force, and the patient decides what they want to do. It's like telling a surgeon how a surgery should be done. Like I always crack a joke on a bigger platform or a podium, that am I in a position to tell my surgeon how a surgery is done and how he has to put his stitches, and this is not the way I want it to be done. I mean, I don't take that liberty of doing it. Neither any of you practitioners would do that. So, I at some point of time, we have to deliver something which is required by the patient. So we have to get into counseling or explaining why it is needed, so that we can get to the optimum outcome. So after sharing the literature, what we usually do is we share markings on the prep, which are to be modified. The clinician then modifies and sends out the new impression. We also provide the clinic with reduction coping. In certain situation when we work for overseas or outstation clinics, where it is not possible for for a big case, if I have to struggle with one prep, we just provide them a solution like a reduction coping, where the slit of the coping, or there is a slot in the area which is to be reduced before you take the trial, or before you even try the restoration, and it can be easily modified, and you can simply place your restorations which are being delivered by us. So in some rare situations, we will find that we have another impressions, and there are no modifications been done. We get this also. So it's been promised and it's been told that we will modify this. We send them everything, and the next day or the day later, we would probably sit across comparing two models and finding out that nothing has been done. So people people tend to accept that, okay, I'll do it, but then the problem is that I didn't have time. So this is basically a reduction coping. So you place the reduction coping. We make it in pattern resin. Sometimes for a bigger case, we cast it in base metal alloy. It's like a regular coping. You just put it in. The exposed surface needs to be trimmed. So here in this situation, you can see the incisal 1/3 was not prepped well. It was staying out of the arch. So I just made a coping with Durale or pattern resin. Just reduce the tip of it, this part of it, and you can fix your crown. Pretty easy and non-expensive solution, I would say. So what are good margins? So good margins are like 360 well prepped. Now these are bad margins, they're not margins at all. These are again situation where there is no isolation being done. Uh, Simply took some material in the tray and loaded it. The deadliest margin is this. You can see that there is a complete, a mass of impression material which is flown across the prep over onto the margin, and there's an overlap. So you can see this has been not, this has been picked up or taken out too early before even the material was setting, and there is a pull or a tear in the impression material. So, as I mentioned earlier, read your impressions. If you read your impressions, you still have the patient in the chair, right? You can still manage to do a good job, because I think the prep was not too bad. The attempt of making the prep was not too bad, but the impression, has a very important role to play. So, what are margins? So, knife edge margin is something what predominantly people tend to do till to it. Uh, it's also been modified to call it verti prep now. Ideally speaking, what we prefer is a small chamfer or an extended chamfer, beveled shoulder, a small shoulder, and to anterior restoration. And when I say laminates, if you have a diastema closure, it's better to prep it more proximally and take the finish law more lingually, because the contact points are more lingual. In that situation, what happens is I can get more surface. So there in an anterior tooth there is a mesial and distal surface. I can get more surface and the line angles closer to the center of the tooth, so that the visible width of the teeth are not that wide, especially in a diastema closure case. And in that, we can also squeeze in the papilla, because I also tend to lecture on aspect of smile designing, and in that the biggest topic is phonetics. So since we do restoration, it doesn't mean that the patient he cannot or patient will have to live a everyday life to the requirement. And we have been dealing with patients who are into different professions like singing or theater and movies. So I did Amitabh, I did Lata Mangeshkar. I cannot just leave them with some black triangle and then there is a problem in their speech or phonetics, especially when they are a singer. So even with digital impressions, you can see there is a scan which is been not recorded well, and that's without a cord. And now the same scan, once the cord has been used. So we suggested them, we get these scans, and there are people who verify the scans. Like we have people to verify impressions, and we gave them an input that this is how it is. So they wanted a solution, and we told them, okay, just trying to use some retraction cord, or maybe retract it with your 3M gel, and take another scan, and you can see the difference. You can see how good the prep looks like, and how nicely it has been restored. So you can do something like that, a small trick. So most common thing is common messages what we get. So these are, I'm sharing some WhatsApp communication. So in our office we have made WhatsApp groups for uh, probably all the clinicians or most of the clinicians who work with us on everyday basis. So there is a less clearance. So here you see less clearance, drag on model, scrape it. Another case, drag on tooth between the both teeth, will have fitting issues, scrape and so on. So that's the most common thing what we get. We tend to go ahead sometimes and do it. We are a commercial lab, we need to do it with our instinct, but many a times we have to send it back. So a good clearance is something which will make your life easy because the restoration will have a life to it. Bad clearance will definitely over a period of time. See, basically it is something which has already a problem in the occlusion. You can see this area, it's already in a crossbite situation. There is a good amount of wear here and a very less amount of space or clearance here. So what will happen finally? This restoration is going to fail. And in today's generation, it doesn't really bother to the clinician because we always claim that there is a warranty to it. From our side, we don't extend any warranty to any of our products because we warrant the product will stay, provided it is followed as per what we agree with, and we are blessed to have good clinicians to agree with us. So a deadly clearance would be something like this, where there are preps with done, and everybody, I mean, every prep, every tooth is in contact with the opposite tooth. So this is a big no. This is going to fail in no time. So what exactly is our requirement? So the pure objective is material or case selection of material, and then you can prep it accordingly. So if you don't have any adequate clearance, the what happens? The processes will fracture inevitably, maybe immediately or down the line. So we can assure you that it will fail maybe in some time to come. In the last picture, what you saw, it will fail immediately. So Emax would be 1.2 to 1 mm. This is now the basics, but I would go ahead if you are doing inlay only, then you have to understand where the plunger cusp is, the opposing cusp, and from the height of isthmus to the opposing cusp, it should be around 1.8 mm. So zirconia monolithic, we can get away with 1.5. Now there is a misconception that PFM requires less clearance than zirconia. Zirconia requires less clearance than PFM. Yeah, PFM requires more clearance because there you have a metal interface, a coping, then there is a opaquer, and then there has to be sufficient amount of porcelain to hold on to that metal, which can withstand that kind of forces because mastication or occlusion forces are massive. Now, having said that, if you don't give that kind of clearance to PFM, what will happen? The ceramic will fracture. There is nothing going to happen with the metal. Uh, Also, sometimes you will see that the ceramic is shattered. Why? Because now the lab has gone ahead and did the coping so thin, like this, like 0.3, zero point 0.4. And when you have that kind of lateral and vertical forces, what happens? The metal flexes. Metal flex, what the first thing what will do is it will leave the porcelain, will shatter the porcelain because it's glass. And what is the strength of ceramic which is layered over metal? 120 megapascal, 110 megapascal. It's strong enough, but it's fragile because finally it's glass. Metal is, good 1 mm is all right. It's not a problem. So how this situation, the whole thing started. So the whole aspect started with model analysis. The situation in the hand is conveyed to the clinic. Here are the usual three outcomes. We'll go ahead with PFM with metal island. We'll accordingly adjust the opposing tooth. So what we do is when there is a prep which is already closed, we ask the clinician that we will mark the opposite whether they are ready to do it. And in certain situation where it is a PFM, we will leave that metal part. We will not reduce the coping up to an extent where it will fracture. So we will give a metal island kind of it. And then once it is been discussed, then then we wait for the reward, and then we put the case on hold. By this time, the doctor has decided because he has gone through the process of looking into the impressions, the models, the pictures. So we have two professional photographers in our office who take pictures for everything and share it with the clinic through the communication channel, email or WhatsApp. WhatsApp being the easiest way now. By this time, he agrees to it that yeah, there is some problem, and he is ready to send a new impression. And still, he's asking, can we work on this model? which we have already discussed. So we mentioned that it is difficult. So there is a new model which is apparently coming up. Another situation is then, selection of material. So if there is no sufficient clearance in the mouth where there is a Emax inlay being asked for, or a kind of an overlay, we called a clinician and told them that this is not going to work because Emax would fracture, as you can see. But we have another material. We have something like a hybrid composite from like graphene or HIPC. So we agreed that, since Emax will break, we will provide you with something else. And they said, okay, go ahead. So the most common thing is, please proceed. I cannot call the patient again. It's an urgent case. Everybody is traveling. I don't know where they are traveling, but everybody in our office, we get to hear that the patient is traveling. And the last but not least is, I have not seen the patient. My assistant has done this case. So that onus doesn't lie on the clinician who is running that office. It's somebody else's mistake. So if it doesn't sit every time, it's a lab mistake. If the impressions are not good, it's the clinical assistant. If the communication is not good, it's again on us. But we make it very clear that everything is in black and white. It makes life easy. We can go back. We can refer to what we had spoken, what we have done. We can refer to the pictures. So you can see these are kind of a pictures what we send to the clinician, so that they get a first-hand information. So this is why communication has become a very, very important aspect, and you need people to communicate. So in my office, we have around 8 people, 8 or 9 guys to handle the communication part, and a few of them are dentists, and on top of it, I have 2 professional photographers just documenting it every hour, every day. So having said that, I mean, we have to see this. I mean, it's like a heartbreaker, because it costs a lot of time and money to produce something, and it just fractures. Please repeat. So that is something what we can avoid. So can we avoid it? We can avoid it by case planning and choice of material, and these goes hand in hand. So if you plan a case, we extensively discuss it with the clinician. What kind of materials can be used? What are the possibilities? Because certain times the clinician has promised something like a metal-free restoration or a zirconia on a full arch, and there are a couple of pontics, more than 2 or 3 pontics in the procedures, you just can't do it. And then we have another alternative. Then we can give them some suggestions as a lab. So what are the most common materials being used? A is zirconia. So we have full contour in the interior and posterior, full contour 3-unit bridges. These are basically zirconia which are 5 yttria. So there is a limitation. Again, you have to understand, there are zirconia with limitations, and then there is zirconia for full arch reconstruction. There are zirconia for implant restoration. It's not that one size fits all. So you have to be a part. That's why I said that the lab has to be a part of the clinic, and the lab has to be a part of the treatment planning team. So what are contraindications for zirconia? Now zirconia, there is no contraindications in most of the clinic. Everything works. So it's not that. We have seen zirconia fractures. There are some catastrophic, things happened with zirconia, full arches or implants. We have to understand the conditions. Patients with severely reduced residual dentition or severely wear pattern, any other listed indication like bruxism or any other habits which the clinician never shares, or when we trying to see the clinical pictures, we ask them that this is what it is, and if that is so, then we'll have to try and find out some other solution. The most important aspect of zirconia fracturing, when we do a big case, multiple units or a full arch, it's been cemented with a temporary cement. So when you do a temporary cement, for the sake of understanding, it will fracture. It is a big contraindication for any zirconia or metal-free restoration to be cemented with temporary cement. That's something which one has to, have a very big clarity on. Veneers in lithium disilicate, I do 0.3, 0.4 laminates as well. We can do inlays, onlays, linear, partial crown, minimal invasive, implant superstructure. We do a lot of what I can say, customized abutments in zirconia or lithium disilicate over metal substructures. 3-unit bridges I don't tend to do very often now, but the contraindications are again severely reduced dentitions and sharp edges. Of course, I mean, it's needed to be added here. Sharp edges, especially when we do laminates, it needs to be rounded in the prep requirement. Uh, Second and most important aspect for me is the bite. Now, what is a good bite? A good bite is something which will correlate to the exact situation what you see in the patient mouth. So, what a no bite is a bad. You can see there is a situation and we have called for a bite and we have been told, can we manage a trial without a bite? Now, if the upper and lower are not occluding within themselves, how do you go ahead and proceed something for a trial? I can't imagine. I don't know the formula behind. The deadly bite is that triple tray. This is a triple tray impression. It's been poured, it's been mounted as per the situation, and there is no relation to each other. Now that's a bridge. So again, I said, when you do a case planning, you have to do your treatment planning. You have to plan your material. Material includes clinical material as well, not just the lab material. So a triple tray in this situation, you think that it will work. Triple tray only works when there is a distal stop or the last there is one tooth which is occluding with the last tooth, so that you can register the bite as well as you can register an impression, and it is for smaller units, single units, not a bridge. So these kind of indications are when the manufacturer says that this is not supposed to be used here, and if you use that and go back to the lab and say, you know what, I know everything in life, kindly just go ahead and do it. That's not just gonna work. So getting the right bite. These are some illustrations from. I refer to a lot of books and I buy a lot of books. Uh, this is from Maro Fradini. Uh, this is how this is easy. Again, as I said, I basically like to read books and learn from them and simply copy them. So this is where the good centric is. You can see how the vertical dimension has been measured by using a simple caliper, which we used to use it in the school, and verified, cross verified with the diagnostic, again cross verified during the mounting, and this is how a good bite would give you an optimum result for which the final restoration was already planned into occlusion by making provisions. So another good trick is to give something like this, a resin try. So what we do is we basically print everything, we design everything, we print it in resin. This is a big complex implant situation, a big case, so we cannot really go wrong anywhere in terms of occlusion. And we send it to the clinician. The clinician at ease can take this as a trial in occlusion. Leave the patients for a while, I mean, in the clinic itself. Let the patient get used to it. The patient will tell how comfortable they are. And you can analyze the phonetics, you can analyze the aesthetics, you can analyze smile line, you can analyze occlusion, you can analyze everything out there. And the easiest part is you can correct it because it's a resin. You can grind it very easy. If you want to add it, it's resin. You can use some flowable and you can add up anything and you can get it in occlusion. So the possibilities are immense here. And the moment you get there, your patients are comfortable. They know that something now is coming and will be comfortable. At this point, if the patient is not comfortable, he's going to tell you that he is not comfortable. You can go back and analyze what needs to be done. Now, if I don't do this, what happens? What happens is I deliver the final prosthesis, and now we are all scratching our head what is going on. And the patient is sitting in the chair with a lot of anxiety. The worst part is the patient doesn't come alone anytime when this is supposed to be done. There will be 2 or 3 of his relatives or friends who will have more influence of what's happening in his mouth. So having said that, we need to consider all these factors because trust me, this is something what we face every day. Instructions. what is good instruction? A good instruction is something like this, which we get, a complete instruction of a complete instruction sheet of what is supposed to be done, what's crown is supposed to be done. You can see there is a small note here, and what shade to be done. Here is another instruction, a big case. B2 shade, speak to doctor. Now what happens is this is a time killer. Why time killer? Because when we call, the doctor is busy. When the doctor calls, our phones must be engaged or busy. We need to cheer each other. And I'll go to the timeline. When you have a crunch situation and we send a note like this, we have to stop till the instructions come because we don't know what to do. What kind of crown to be made, what is supposed to be done, whether there is a bite which is going to come, is there anything which is which has been documented or registered in terms of pictures or in terms of some communication with the patient. Nothing is known. Nothing is known. So that's one thing what we can avoid because it just kills the time. And the dreadful is there is a pickup after 12 in the midnight. So we get these kind of things as well. So what makes life easy is we have printed something like this, where we have made this into a e format as well. We send it to the clinician. This has pretty much everything, in all for what we need to know. This is all the services. This is what you have sent, the enclosures, uh, aesthetic information. Most important when I do my laminates or smile designing is the length of central incisor, any shape. Now in digital dentistry, we have different mold charts or different, we have a possibility of working on different mold. So we share the mold chart with the clinician to let them assess what kind of mold they want to do. And then accordingly, we can select the library and we can go ahead and copy the same. Whether they need surface texture, what kind of context they need, what kind of margins have been prepared. Everything is quite elaborate on a single sheet of paper. But uh, and then we get a call. Have done the prep. What material we should go for? I mean, it's very easy. Just mark it down. Just tick in the box. But second most important. I mean, this is quite funny at times. But when we ask pictures for some shade, now these are the pictures which came for the shade. How do you assess this? What kind of judgment can you make? Look at the light. Look at the kind of picture. The teeth are small, but the face is quite elaborate here, quite big. We can't. It just this doesn't work. So when we get a good picture, we can produce something like smile stimulation. Now this really works. This is a good tool to develop your business as well because herein you can show a before after to the patient before actually not doing anything. And this is a good marketing tool as well because now you get the confidence of the patient that my doctor knows what he's doing. And in today's generation, uh, people tend to agree what digital would do or what electronically we can provide them. Because in dentistry, is this is one of the profession we still are into where everything is done by bare two hands. And when you add some science or some technology to it, it becomes easier to sell. Otherwise, the dentist whole time convinces the patient for what experience he has, some past cases what he has done, or some videos what he has probably downloaded or bought somewhere. So, having said that, this is just a stimulation for what we can do to the patient. This is a case. You can see this came for smile designing. This was the before. This is the stimulation what we did, and we can make a small video like this and give it to the patient. Now here, of course, the colors are too stark because we want them to notice the teeth more rather than the facial characters. So here you can see from where we came. I'll just go back. So here from where we came, a retracted image, and we converted the same smile into something what we can deliver. And we did this case in the same way. Now what happens once this is approved, we take this same, then this is not 2D, this is 3D. So we can take this same mold, we can print a model. So what that model becomes? Now that model becomes a diagnostic vaccine, which you can use it for your prep guide, which you can use it as a transfer guide, which you can use it for your analysis, which you can use it as a long-term provision. And you can then make changes there. Again, why? Because it's a retracing. All right. Now these are the set of pictures what we need. So we have small PDFs for many things in life, So we share this with the clinic. So when I say full face, we have a complete instruction on how a full face is needed. Smile without retractor, profile pictures, high smile line. E position. E position is important because now you need to analyze, how much is the vertical dimension of the smile. Maximum intercuspation, rest position. Rest position will give us the buccal corridors as well. A smile when with teeth apart, and the most important is when you ask the patient to lie down and take a picture from the top. So that indicates how the alignment is, how the smile arch form is. And a normal picture or an old picture where the patient sometimes wants to say that these are my wedding pictures. Now I'm 65, 70, but I need to look like what I was by then. And we get old pictures which are many a times, black and white, and we try and copy the same thing. It just gives us the perception of what mold size the patient desired to. Now, if you don't have camera, so we have a small clinical setup in our office. That's a black background you can see, and as I mentioned, we have photographers with us, so we document the case. We take pictures. We get patients every day for shade. We get patients every day for for documentation or for analysis. Nowadays, clinicians just send the patient to the lab so that we can see the patient. I make them sit, speak with them for some time, what they desire, what they do in life, why they need a smile design. Because nowadays, with different walks of life, a lot of people, a lot of my patients, they are into professions which are which are into glamour industry. So then we can decide whether we want to do it in bleach shade, whether they are coming on the screen, so we can discuss about whether they want to brighten their smile, so that we can have a choice of ingot accordingly. We can offer them the shade guide where they can spend some time. This is not there in the clinic. So then and when they get to see the lab, which is like now we have a like 2, 3 story lab, then they realize that there is something like this which is seriously going on behind the teeth or smile. So time, the perpetual challenge is that every case is urgent. Most common thing is that the patient has a flight, as I mentioned earlier. I don't know where they fly, where they go, but everybody has to fly out, and there is no time at all. And trust me, these kind of cases, when they are into a loop, the patient don't tend to go anywhere. We just have to go back and forth to just finish off and complete the case. Now, in today's days, we don't have this kind of situation. We don't regularly do these kind of things because we work onto a more predictable outcome by doing all the trials, by doing all the jigs, by verifying at every point of time, so that on the final day that the patient can catch the flight for where he is supposed to go. So we are very particular about that. So when we say that when we tend to be rushed for a case, the only solution is that we can tell them that the work is still in process and we need some time. So let's touch upon the few things about implantology, since I believe most of you are also practicing implantologists. So what is primary physical impression? So if I have an impression like this, where the impression post is not even engaged well and it is moving all over, there is no way this is gonna work. Again, you see how the wash is been flowing all over the putty, not in the area of work. You see how this impression was made? The light body, where it is supposed to be flowing in and around the teeth surface, has flown in the palate area. And there is nothing left of. So this impression is not caught well. Most important aspect into implant dentistry is verifying the impression post. When Verifying the impression post by taking a radiograph. Many doctors, or most of them, don't do it. They just don't agree to do it. They just don't agree to do it because it costs them some more few minutes, extra minutes to do this. But in many cases, you would see in many implant pose situation where there is a hex or even a trichannel, you will get the perception that it is sitting, but it can sit intermediate and the screw also gets tightened. So, then in that situation, it becomes very difficult for us to assess. So we try and send them a verification J. With bigger cases, it is always better that you have an open trade. What happens? We need to push into the impression. And if there is a small marginal macro level change, this is not going to say. This is not going to be, this does really doesn't work. But with closed impression coping, what happens? It is engaged inside the impression coping, inside the impression material, along with the tray, and it becomes as a complete impression, and you can easily retrieve it by taking the screws out. So we can provide with this kind of trays. So regarding digital implantology, this is a primary scan. So when we say a primary scan, many a times, people tend to use scanners these days, but when they buy a scanner, now whatever earlier problems I had been mentioning regarding impression, they feel that they have walked out here. Now I have a scanner. Now I don't need a lab to tell me what I'm supposed to do with my impression. Now I don't need a chairside assistant to tell me that I don't have to blame my chairside assistant also, because now I have a scanner. But trust me, digital dentistry is more challenging. Digital dentistry is something which needs to be understood. Digital dentistry needs a learning curve. Digital dentistry needs some kind of basic clarity into how the prep should be, how one should, go about, like a good impression, a technique guy would probably would face less challenges during this transition of going from analog to digital. Just a moment, excuse me, Rian. So that's one thing what we need to learn. Having said that, I will not take a lot of time over here, but there is something called as the stitching. So when I say stitching, when you take the scanner, we need to take the scanner in a certain way, and scanners are sold mostly by the reps or by the guy who represent or work in the company who doesn't know anything about it. All right, they have been trained for one day and they have been sent as a marketing guy, and that's the guy who demos most of the time, as far as I understand. So when it happens, there is something called as stitching. Stitching is like, reading data. So when the data is stitched together, you get a complete wholesome image. So scanner is nothing but a digital camera which picks up images very rapidly, convert them into a PLV file. A PLV file is converted into an STL file. So once this reaches, we have a data analysis. We put it into our software and we analyze for what we see. And then according to that, we can analyze whether there is an. So we go through the cross section of everything, and then we can read the scans well. So this is how we tend to look into it. You can see we can also measure the clearance for what we need. How we can how if we plan a restoration of a molar, where exactly the clearance is more, where exactly the clearance is less, how good the margins are. If it's less than the desired, then it's going to fracture. We share this kind of images with the clinician. Most common problem is the double scan. You can see that the scanner is rated twice, one over the other, uh, and it has given an image which is kind of a scattered image, not something which resembles the prep. Implant dentistry scanning becomes really tricky if you don't engage the scan bodies well. Now, when I say you have to engage the scan bodies are nothing but simple readable radio opaque devices. So here you see how the scan body has been registered well is have these kind of slots. Now these are the areas where we need to orientation. Now what happens when I get this impression, or when I get this digital impression or a digital scan is, we have to import these from the library and we have to merge it. So there is a library, there's a data with each system and with each implant size and with each impression or the digital scan body. So there are various third-party digital scan body manufacturers also. They have their own library. Suppose I am using Noble. So Noble would give you a Noble Biocare scan body. Noble would also have something from Aurum, which we provide. Then they would have something which they have outsourced from a third party. So you have to get to the code. There is a code, and that code resembles something which we have in our library, which we have downloaded. So in one system, there can be a different library available. So if you are going digital, just verify which system you use, what scan bodies you get, and then accordingly you can communicate with the lab. Uh, how do we verify it? Simple jig. So with all implant cases, we send a verification jig. Even if it's a direct finish, we send a verification jig so that the impression, so that the model is transferred into the intraorally by using this jig, so that you can fix the abutment, place the jig, and screw the abutment so the position is similar to the model and intraorally. Now, what happens if I don't do this? They take all the abutments out. Now they don't know which one belongs to it, and the clinician places the abutment which is in the mesial to the distal and the distal to the mesial and calls and says, boss, though this is not sitting at all. But now what I have? I have all the pictures which we have sent. I have all the verification jig which we have made. Now the jig is lying in the box. But this guy is not bothered to use it because I know everything in life. I know how to handle it. So we tell them that just verify the jig. And they say, you know what? I don't know what you guys have done. The jig is not even sitting. So it's a clear-cut indication that there is a mix-up. So and so much so that we have to mark the buckle and lingual also. So you can see that B belongs to buckle. Otherwise, they place the jig on the other side and they say, no, you know what, this doesn't sit. So we have to be very, very cautious about working with a clinician for what a lab needs to be, and we do that. So once that is done, you can radiographically verify the jig and the position of the abutment. In both situation, it has been done, and then it's just transfer of from the model to the to intraoral. So if you have verified the jig, you can see that the crowns are seating well. They have no problem with the margin. They have no problem with the occlusion. So what happens if the jigs are not seating? You can whether you can uh, still go ahead and do it. Yes, you can with some modification. So if the jig doesn't sit, that doesn't mean you have to start with the impression again, or for us to start with the whole process again, because we have made the model, we have mounted the model, we have sent your jig. Now, if the jig doesn't sit, uh, what we will do is we will try and mill the abutment further, but in some certain situation, you can split the jig. Now, this is a cross-arch situation. So, okay. Now, here again there is a challenging thing. There are two aspects to implantology: engaging and non-engaging. Here, what I have shown you, simple engaging abutments. Here, this is our multi-unit, which is a non-engaging abutment. Now, again, the problem is with incorrect part solution. What we have asked is basically a non-X abutment for 4-6 and 4-5, because now they are supposed to be joined. And if they want to make us into PFM, then we can call for a castable abutment, or we can print it ourselves, or we can print it in metal DMLS. But we need one X abutment, because now that one guy is, we can't use a non-engaging in a single tooth situation. We need an engaging. So the doctor says that we can give one hex and one non-hex on two joint crowns. So he needs one hex and he needs one non-hex, because that is what he has. Whether that works in certain situation, maybe, if there is a parallelism between the implants. But if there are two implants which are diagonally, across each other, then the insertion direction won't allow the hex position to be coinciding with the non-hex position. So because these are now two joint crowns, so there has to be a parallelism in the insertion direction. And mind you, when it comes to implantology, it's all about, it's not just placing implants and making crowns. It's about understanding biomechanics. There is something called as the biomechanics to it. There is something, there is a large amount of physics which goes into understanding implant restoration when we design it or make it. So we need a lot of communication when we do big implant situation. So in a cross arch situation, now the jig doesn't sit. What the clinician has done it, he has split the jig into two parts or three parts, and just use some, some resin. Now these are resins which are made specially for these kind of situation, and or you can use Durale or pattern resin. And he has taken the jig back again to the patient and verified it intraorally, screwed it. He checked again. Now what? Why this has happened? Wrong impression. This was not an open tray impression. This was a closed tray impression. We made the model. We tried to tell the doctor that this is how it will be. We agreed that we will verify it with the jig, and then we have done the same thing. Patient is still there. It's verified by the clinician. Now this thing happens, right? It is not going to sit on the model. Now why? Because there is a change. What happens now? Do I take another impression? No. What we do is we do a model surgery. What is model surgery? We change the situation on the model by changing the position of this lab analog, removing it as the plaster, engaging into this jig, and pouring some resin in and around it. So that now what I have the same situation intraorally on my model. Why I don't insist on making another impression? Because as I said earlier, we have made the model, we have made the bites, we have made the setup because we have to do a setup. Now, I can't call the patient back and forth. So we need to make the jig as well as the setup at that point of time to verify the vertical, or we need to send a bite block. So once we have done so many process, I can't go back and make another model because that will be entirely different situation. I'll have to start with the first step. So we try and respect our time as well. So this was the situation, and then we salvaged it. Nowadays we try and make it even easier. We make a CAD design printed jig with the printed resin and send it to the clinic so that we can verify it. And these are pretty strong and sturdy, not like the pattern resin ones. They are like stone jigs. Uh, Again, vertical dimension. So, prosthetic complications do happen if you don't consider occlusion. As I said, occlusion is something what I really look up to. Now, this was a very old case, a old design. Nowadays, we don't do wraparound in similar situations. And this is actually not our case, but it came for a repair. But this is an old case, old design. You can see how the teeth has left the frame. This was actually a PFM situation, but the design itself was such a faulty thing. They have not done it well for the space existing, and everything shattered there. So vertical dimension plays a very important role. So coordination with the lab. So this is another situation. Resin trial been done, looks great. Some small changes, please. Line angles too sharp. Would like to improve them in the final minimum thickness of file. So what happens? Now this is the setup. This is something what we verified first. Once that was verified, everything was approved upon. We made a jig. This is what I have showed you earlier. We made a verification jig depending on the final design or the final, restoration what we have planned. Once that has been said, the doctor gave us the feedback that everything is approved and final. Now he is more confident about what he is trying to do or deliver. We can make it more easier by using what I can say surgical guides. I'll go about that. So about vertical dimension. Vertical dimension is basically the most important aspect in today's dentistry, especially when we practice implant and when we practice full arch. So I mean, this had to be interactive, but since I'm speaking alone, if I was in the podium, I usually ask, what are the biggest challenges into restoring and full arch implant situation in our country? And the most important and the most challenging aspect is vertical dimension. See, we are timid people. We are not like Europeans. What the Europeans basically show, or what social media shows, is basically with a lot of vertical. So I always say there is a lot of playground. With our kind of situation, you will always have to find with the inter-arch distances, with the vertical dimension, and accordingly to we will have to choose the material, we will have to choose the design, and we will have to do a restoration. So ideal vertical, full mouth should be around 20 to 25. We sometimes get as good as 14 to 18 as well. So, vertical dimension, I'm not getting into detail about it, but there are a lot of aspects which we need to consider between the inter-arch distances. So the inter-arch distance refers to the vertical distance between the incisal edges of the maxillary and mandibular incisal, as I showed in my earlier illustration, or a picture, where you can really physically measure the same if you have dentulous teeth, or even if you have dentulous, then you can plan your setup and you can verify the same. You can plan your setup by verifying the vertical dimension when you do your bite restoration, and measure the inter-arch distances. So in that you have to check various aspects like the occlusal plane, the curve of speed, the curve of Wilson. Everything needs to be verified during the setup, and you need to verify it intraorally as well. You have to you have to also consider the prosthetic design, looking at the inter-arch distances. Uh, Ideal dimension of the teeth with the present video. So that means the mold chart or the mold size. Uh, some patient history, very important, because if the patient is into a habit, then we'll have to plan it accordingly and give something which is required once we are done with the treatment, like night guards, and if it's a bruxer, or if there is an habit, we can give something like a deprogrammer before even we start the treatment. So that kind of primary analysis is very important. Then we can go ahead with diagnostic wax-ups, facial analysis software, radiographic imaging. All those things comes into consideration. So vertical dimension is the driving force for any restoration which is implant. And if you go in and around all these topics, all these aspects, and touch upon that, then you will realize that how involved you are into this. Okay. Now, with implant positions, now this is the case where you see the how the implants are being placed, and they are all divergent to each other, but we still made a very good restoration out of this. I'm not in a position to show you this entire case, but this is a case post-COVID. This patient had mucormycosis, and you can see there is a big cavity. This patient already has a cancer, and we had to replace him by giving a fixed restoration as well as a removable. So this is a very challenging case I did for somebody. We also tend to do surgical guides. As I mentioned, communication and planning. We also tend to communicate with the clinic for what can be done with implant restoration, and we provide them with guides. We also do various guides. We also provide them with surgical guides which are stackable, so one above the other. So you have a primary guide, you have a bone guide. On top of it, you can have an implant surgical guide, and then on top of it, you will have something like a immediate provisional. Some few things into anterior restoration with high-end aesthetics. Here you can see there are two implants which is in place. We made provisionals.
Sorry to
Immediate
interrupt,
provisional.
sir. So sorry to
Yes.
interrupt. I think the presentation is stuck, sir. Actually, I think the slides are not moving.
Okay. Okay.
Okay,
Going
now
on.
it's moving. Now it's moving,
Now
sir.
it's moving. So we got stuck here. Okay. Just let me know which was the last slide we got stuck.
I think it was the slide regarding about the prosthetically driven the full arch.
Okay.
Yes, sir. This one.
Okay. 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 So I have already spoken about vertical dimension. Not much of illustration here. I'll go ahead. This is the situation where these are the real challenges of our life. Here you can see there is a case of mucormycosis, how the implants have been placed. There is a cavity where the patient had cancer, and we need to design a restoration. If time permits, maybe some other day I can show you this entire case. We did a fixed restoration in the front, and we had a removable ear because there is an obturator. Obturator cannot be fixed, so we give two prostheses to one, and the one in the front is fixed, and the obturator part is removable, but it is also lying over attachments, so it can be treated as fixed as well, but it can be easily maintained. So we also provide you with surgical guides. As I said, various surgical guides can be made. This is another situation where you can see we have made immediate provisional so that the papilla can be managed well. These are the immediate provisionals. These are the CAD designs. Uh, this was the first step. The second step where we copied the provisional which were already there. We modified. We took that file. We made provisionals here. This is how the gingiva looks like once we were ready. I made here I did something different. I made two zirconia copings, but now you see how the copings are made. The copings are made in such a way that they are laminated. Okay, because I wanted high-end aesthetics. I like using Emax. I do a lot of laminates on every day. That's what I still. If you come to my office, I still work on the bench. I finish every day, and I like to do my work with my parents. I have a good team, but I like to do. So you can see the final outcome was really nice. We modified the provisionals. We used the provisional and we scanned that provisional. We used that data to create these two copings, which are made out of zirconia. I made two wax ups on top of it, like Emax veneers. So you can see this is the zirconia core. That's the Emax restoration, final glaze. These are the zirconia copings, and that's the final outcome with Emax. So that's the final outcome on the day it was cemented. Now the papilla is even better. So design modification. So you can see there are certain teeth where there is an accessole which is coming facial. We tried to modify this, but it is going way out of the arch. We tried to modify it in another way out of the arch. What we did was we did a ceramic restoration and we made a 3-unit bridge so that the accessoles are lying inside. So it's a small solution to situation like that. A few clinical cases now. So when I say digital smile designing, I would say what is digital smile design? It's basically understanding patient requirement, treatment plan, convincing the patient, treatment execution, and follow-ups. So these are the few steps. Uh, Now I have one situation. Yeah, this is a good case. Young guy, about 40, deep bite, heavily crowded, worn down dentition. He's a good friend of mine, and he's a leading guy, heading a big IT company in the US and India. So he needs to be presentable. He's always on the move. He meets high-profile clients, and his business takes him to places. So his primary concern was that he needs to restore his smile as well as he needs to restore his vertical dimension, because I will show the intra further. So we discussed with my practitioner that what we need to do, and according to that we made a treatment plan. So this is basically between me and the clinician. There was an email which we got, and he says that we need to open up the deep bite. So again, coming back to communication, this is the basically kind of communication what we get and what we do with our clinicians. And This guy basically used to practice in Mumbai, and now he's practicing in the UK. So these emails were sent from UK. This patient was partly treated in the UK, and we partly treated in Europe. So we opening up the deep bite, protecting lower arteries for further wear, increase in inter incisional space or vertical dimension, to restore loss form. Maximum intercussion is CR. CR is most important aspect, as I showed earlier, how to register a CR. That's again a big topic which Dawson teaches in a very extensive way. Really expand the arch also because we need to decrowd the arches from both the arches. So to start with, we said that let's start with aligners. We also make aligners in our office, and we primarily do aligners for these kind of situation, and also on general aligners. So our main aligner treatment was planned, and we also had a small restoration to be done. Clinical pictures were shared later. So these are his day one clinical pictures. You can see we have started with the aligner treatment, and we gave him the design of the aligners. Uh, we made almost, I think, 22 upper and lower aligners for this. Uh, and we use something called as a pro sheet. So we use sheets from a company called Shoy. We are Shoy certified lab. We are FDA certified lab. A Shoy certified lab. Shoy is something which comes from Germany. So we don't use sheets which are like, there are a lot of companies in India who make sheets on their own. Those doesn't work. Uh, we have retreated many cases where they were already being treated for aligners. So now look at the outcome. The desired outcome will be in 40 weeks. Okay, so we waited for the same. We started with this. This is the first zero aligner. After a while, so it's a big story, right? Now he has a detailed chat with the patient. His Preeta aligned almost 90%, which we thought was good to start with. Lowers, there were some retainers still to be done, and lowers we will be finished. He's traveling to the US in the May. Before that, he needs his provisionals, and then we can finally do the final restoration. This was the plan. So I agreed with that plan. So the preps were done. So the preps were done. Impressions were ready to be picked up. My office started communicating with him. We said with once we will pour it, we will have an anterior jig. We will mount it. Any confusion, we will call. I said we will make models and check it myself and then communicate for the same. This is where the stimulation starts. This is now we have started since we have reached a point where we can start the treatment. This is how we plan it. This is the before and after of this patient. We showed it to the patient. The clinician made us do some changes for what he felt needs to be done. These are the final outcome of a mock-up. A digital mock-up was made, so you can see just an additive on the existing teeth, so that we can understand how it will look like, and this will help us in understanding the whole situation and the prep requirement also. This was printed to be made into provisional. So these are my diagnostic wax-ups now, uh, and you can see how good the occlusion is been planned. This was basically gross prepped and transferred as intraorally as in a chairside provisional. Then he further ahead made us do the final provisional, which we milled into PMMA resin, and we gave a final provisional. Now you can see the vertical is opening up. We can get some more space. We made another set of provisionals again after checking the occlusion, so that we can get some more with the lower anteriors because they were not discluding. So here what I'm doing is I'm playing with the provisional. It's very easy, less expensive, less time consuming. So now the patient has been left with the provisional. Now he has something to say. He feels that the centrals are looking too bulbous and boxy. We need to check the zenith of certain teeth and so on and so forth. So I said I'll manage the shape. I will do a cutback and I will layer it. Now, having said that, this patient was a bruxer, so we designed. I didn't bother to do a major cutback here. I wanted to do something in monolithic. We did is anterior restoration. This is our classic way of doing it. We do anteriors first. The posteriors are provisionals. I get the canine guidance. I get the disclusion corrected. We check everything with the anteriors, and then it's just replacing the posteriors. So we did anterior restoration. We finalized the anterior restoration, and these are the pictures of the same. So when I say these are the pictures, you can see these are the pictures which goes to the clinic. So now he is ready. Now he knows. So now he is uh, mentally ready for what he is getting. It's not that you open a box and something comes out and now you look at the model and you say, oh, this is not what I was expecting. And you call the lab and the lab has no clue for what is happening. So there is a lot of communication which we need. Now he has fixed the anteriors. He'll say, fantastic, sending the posterior impression. Let me inject and place some cards. No complaint this time. Patient is nice. Anteriors have been cemented. So what we achieved is this zero adjustment. The interiors are said they were cemented on the day it was done. Uh, we took some bites at the phase for reference, and then we started with our all four quadrants. We did a full contour zirconia here. We shared pictures. So every step. So these are the primary before the glaze step pictures. So the doctor verified and he said, okay, we are good. So I said, we will glaze now. So how are you feeling about the bite? I said, looks perfect to me. And these are the glaze pictures. So this goes to the clinician. Now you see they're done well, they're designed well, the occlusion is done nicely. Vinayak case is finished. They didn't need to do a single bit of adjustment. Very well executed. Now this is exactly what we need as a lab from the clinic and from a clinic to the lab. So I said was waiting impatiently to hear from you. Made my weekend. So you can see that feel good factor is there. Now labs most of the time are unhappy. They are always into depression, and I feel most of the clinicians equivalently are into depression because they just know what they have done and they want to do even better. They know they can do better, but probably the lab didn't do the job, or probably they didn't do their job well for something which is now been left as a compromise. So this is the beginning. This is where the end is. You can see how good the vertical was open. We opened it almost by a couple of millimeters, and this is where the starting point was. And these are all monolithic. This is not a very good case, I would say, but this is one of those challenging cases. And you can see intraorally, when I look at this picture, I feel good about it. I feel good about it. I feel that we have really done a good job. Uh, they all are separate crowns except for these two lower anteriors, 1, 2, and 2 are joined because they were very close in terms of prep. Let's look into another situation. Uh, this case we did it in Emax. Yeah, this case we did it in Emax. He's a master chef in one of a very high restaurant in Mumbai, and he's an Italian. He runs a very big Italian restaurant in a five-star hotel here in Mumbai. When he came to the clinic, he already had restorations been done. So he already had PFM restoration via PFG, porcelain fused to gold, and a metal crown. So these are our primary analysis. So this is basically how we communicate. This is what comes from the lab to the lab. So we ask the patient what exactly he's looking at, what he wants. We just don't tell them what we can do, what he wants. According to that, we can plan the material, we can plan the situation. So we decided we will do 9 Emax veneers, and all the restorations were digitally planned. We try to make them digitally complete digital. This is a pre-op situation. This is what I planned for him. So we need some gingival corrections as well, and we need to lengthen the centrals, change the mold size, looking at his facial characters and looking at his videos, which we get a lot of videos of the patient for analysis, and so on and so forth. So this was the first primarily stimulation, planning. Nothing has been done as yet. We made various planning, various stimulation. We zeroed down to this. So these are various planning and simulation. We zeroed down to, I think, this. And then we agreed on something. Once that was done, we printed the model as I showed earlier. The models were used for provisional. This is how the restorations were taken out, the prefs underneath. We made lowers so this is a small video of how the scans were aligned for the bite, and then we can design the same. So this was designed through the CAD, and then we can give all the details. What is the length of central incisor desired. This is all copied upon by the software and from the earlier images what we have. So what I did, I printed this into resin. Since I'm doing Emacs, I printed this whole thing into resin. I make indexes. We make index for everything in life, so we can verify the same. I make index. These are the same mold and same thing. What is agreed from the earlier digital scan data and from the stimulation. I cut it back. I cut back for the layering. I cut it back at the resin stage itself. This is how my final outcome would be. Then I use a lot of colors and I use Emacs serum to layer it. This is my primary layering, so you can see there's a lot of blue. Sorry, a lot of blue, effect one, effect two. Then for the translucency, and so there is a lot of material which goes into layering this. And mind you, there is only layering been done in the interiors. Posteriors we have left as monolithic, right? But this is entirely been done in Emacs, even the posteriors. So you can see the interiors have been now fired and finished. This is his. It went for a trial. We have not glazed it as yet. So this was the first, the digital stimulation, and this is his trial. So once the trial was done, we could verify the same and then further add. So I use a lot of colors and I use a lot of detailing. So I use a lot of color pencils, and this is my everyday job. So this you can see I do when if you come to my office, I'll be doing this. I like to polish my laminates, polish my Emacs, and polish my zirconia, and most of all the restorations. And this is how the final outcome is on the model. So, so these are pictures being taken by us on every day, and this we share it with the clinician. So you can see the balance between the right and left. You can see the anteriors are slightly at a higher level because we need to get it into a centric stop since we slightly opened up the bite. This is at the trial stage. This lateral at the contact view, so it's slightly deviated. So we corrected the same, and sorry, and this is its final outcome. So you can see it came a long way. I'll not go into the entire video because this is a too long video for today. Let's look into something from Crown and Bridge. Okay, this is another situation. Young girl. She had her restorations again done, and it was badly failing. Again, the same thing, same communication. We need PMMA crowns and veneers here. We started with the anteriors by making Emacs restoration. These are the provisionals. These are provisionals what we made, and you can see the provisionals are also nicely glazed and polished. The communication was done. The doctor found that it was slightly masculine, so we worked on the mold. These are the pictures of the models. Uh, and we needed modification. He said, "You just mark it and send it. I'll do the modification." So our clinicians are very positive. So build PMA veneers, he modified it. With this, we can start by making an index of the same. Uh, we have made an alginate impression of the provisional so that we can copy the same for another set of provisionals. So we made another set of provisionals. Once that was approved, we went ahead to do final restoration. Again, the same situation. I printed them into resin, I cut it back and layered it, checked against the index. We need to we verified with the earlier pictures, and the clinician also shared these images with us. We finalized the whole work, and these are the pictures what we shared with the clinic. We said looking good, and then this came out nice. She looks happy, fantastic. This, and then we got a compliment that our cases are coming out like Dr. Dual. We are very close. So Dr. Dual, if you look into his documentation and if you look into his work, it's amazing. Dr. Dual is somebody you should follow if you are doing high-end, aesthetic restoration. So this is the start. This is the basic workflow, and these are the final results. So you can see we came a long way in a nice way, and I think yeah, this is sorry, that was my bad. So there is another situation or a full arch restoration. I will quickly go through it. This is one case where you can see what we call in Mumbai Hindi language is barbad case. Totally mutilated or gone, and the restorations have been done, failing, completely mutilated. Again, the same situation. Another clinic. Uh, we had a bite. We asked the patient, dentist, to get into a proper centric. We discussed about joint crowns or separate crowns, basic level of communication, pictures of the patient. Uh, these are the provisionals. We copied the same for the final. I had implant restorations in the posteriors where when we did this, we made a setup for the same so that it can be verified. From the setup, once the anteriors were fixed, we did the posteriors. So this is in short from where we came, and you can see the doctor has shared that this is where we have started, this is where we have reached, and I mean, it really gives you a feel good pattern. So you can see where the start point is. We restored the whole vertical, we increased the vertical, we completed the whole arch, and it's a process. It does take time, and that's about it. Hope you liked it, and thank you very much. And these are my details. These are our contact info. You can email us. You can send us a scan on this precise CAD cam. These are our social media handle, so you can find them there. Follow us, and then in case any query or anything, just let me know. I'm very open to hear from people, and I mean, I keep on doing this so we can cross our path somewhere down the line.
So thank you so much, sir. So we'll have a few questions session right now,
Yeah.
and
Okay.
I would love to. I would request the audience to post your questions which is relevant to the topic.
All right. If anybody wants to, I think you can unmute them, and you can let them speak.
Sure, sir.
Yeah, because I am trying to interact with them on the meeting chat. But if somebody wants to speak in person, then you can just unmute them. Hello, Shanu.
Yes, sir. Yes, sir.
Can you just unmute them so that we can have an interactive?
Yes,
So
sir.
clear.
They can unmute themselves, sir. Actually, I had given the authority to unmute.
Yeah. Okay, okay, okay. So if anybody wants to speak, we can do that. Um,
Actually, there's one question regarding about the ceramics, the press ceramic and the mill ceramic, which is
Yeah,
preferred.
I am replying to the same. So basically, pressed ceramic is uh, it depends on the situation. But pressed ceramic is bonded restoration, and zirconia. is basically not a bonded restoration. So when you want to get into a bonded restoration situation, you need to have pressed ceramics. Like you cannot do laminates or veneers with zirconia. Now there are people who claim to do that. Now there is a modified resin or ceramic or zirconia. What I can say. There are newer materials also into bonding agent where you can bond zirconia as well. So, but having said that, uh, pressed ceramic is something which is for me. I can work better into anterior restoration if given a choice. But nowadays we have like fifth generation zirconia. Like I use something called a dental direct. They give me a zirconia which is high translucent, and now they have they have their pre-sintered colors as well, which give us a real lifelike restoration. So I do a lot of cases. We do a lot of full arches with. So the last case what I showed you was completely zirconia. There is no layering there. There is no cutback there. It's purely monolithic. So I would not layer zirconia today. I would go in and use a good zirconia, which is at least 5 yttria and multi-layer, and I would use something called as a liquid ceramics over it. So Dental Direct has it. I use something called as Mio Colors, which is again a liquid ceramic, uh, which we use in our office. And I also don't tend to layer lithium disilicate. I like to use them monolithic because nowadays we have a really good liquid ceramic colors which we can simply layer on top of the zirconia and get a three-dimensional effect which look like layered ceramic. So I really don't sit and layer a lot. Unless there is a situation where I have a central incisor and I need to match it with another central incisor, or anterior two restoration, I need to match it. But if I'm doing multiple restorations or across the arch case, then I can play around with the colors. Sorry. So what graphene which you mentioned in a indication? I use graphene. Graphene is basically a hybrid composite, nothing else. It doesn't work in all situations. They came out as a material to replace porcelain, replace everything, but it really didn't work. I use graphene in inlays on this. I use graphene in long-term provision. So thank you, Dental Direct team. I think they joined as well. Oh, I didn't knew you guys are here, but yeah, thanks for joining. Any other question here? I got okay. So I know a few people out here. So any other questions or queries, you can put me onto my, you can send me some of your queries on the WhatsApp as well. You have my number there, so you can might as well. I can follow it up with you. Not a problem.
Okay, so I guess we will wind up, and if any other queries are there, we'll try to answer those queries in our social media platform. Why not?
Yeah, no
Yes, sir.
problem. Just let me know.
Yeah,
Let
sure,
me
sir.
know. All
So
right.
thank you so much, sir, for sharing your knowledge and expertise when it comes towards the lab communication. So surely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed.
Yeah, I think I went overboard with the time. So I mean, since it was late in the evening, but I appreciate that people are still there. So
Yes, sir. Definitely, sir.
next time we will keep it bit early so that you can I can probably show them some few things more.
Definitely, sir. Definitely. We'll try to make another session regarding about this, sir. Definitely.
Sure.
Uh, So thank you
Thank
so
you.
much, sir.
Bye
So
bye.
actually, it was a wonderful and informative session, sir. So we really
Thank
appreciate
you. Appreciate. We were looking forward for something like this again.
Okay. So thank you. Thanks a lot, sir.
All
And
right.
have a great night.
All right. Okay. Yeah. Good night. Bye bye. Thanks a lot. Bye bye.